baby aspirin is a very common adjuvant therapy because it is very commonly used in a lot of men after the age of 50, just a vitamin, like a vitamin. It's very accessible, it's over the counter, and it has an effect. It has a theory. The theory behind is fantastic because it inhibits the COX, the cyclooxygenase, and what is happening is that the thromboxane, the vasoconstrictor, goes down, the prostacyclin, the vasodilator, goes up. It has been shown as cardioprotective. It has been shown to increase the uterine blood flow. And some studies show that it decreases the recurrent abortion in antiphospholipid antibody syndrome. So theoretically, it should be fantastic to use it to our patients with repeated failed IVF. But theory doesn't go with practice, and also it's very difficult to go. I have made a huge work on aspirin, and the duration of aspirin treatment is so various in different studies. Some give as a day one of ovarian stimulation until pregnancy, day one post-fetal heartbeat. And there are various studies, and each study is different in the methodology, so it's difficult to have any conclusion. Anyway, there were low dose of aspirin for IVF has been studied a lot, and when I summarize 10 prospective randomized studies, we see that low dose aspirin has no substantial positive effect on pregnancy and shouldn't be used routinely for women undergoing IVF and ICSI. Routinely, I'm saying. Because as I say at the beginning, most of the studies are done in patients, but not in the extreme place of the Gauss curve. And so you see the meta-analysis, it favors a little bit, but not enough to be significant in usual IVF treatments. What about repeated miscarriages? There are not enough prospective randomized studies. And it has drawbacks, the gastrointestinal bleeding and even major bleeding. And also for the fetus, we are afraid of defects and cleft lip, gastroschisis. We are not sure, there are not enough studies. So it is suggested that available data do not support a teratogenic effect of aspirin, but however, we have to keep it in mind when we give early in the pregnancy aspirin. And it's difficult to stop, because once you give to a repeated failure patient aspirin and she gets finally pregnant, you are so happy and you are freaked, you are afraid to stop the aspirin. So what about glucocorticoids? What is the logic behind glucocorticoids is that pregnancy is is entailing a foreign fetal tissue. And uterine receptivity is controlled by locally acting growth factor, cytokines, and natural killer cells. The excess of natural killer cells activity have been implicated in implantation failure and recurrent miscarriage. So glucocorticoids may improve the intrauterine environment by acting as immunomodulators to reduce the natural killer cell count to the normal range. Again, we have a fantastic theory. Let's see about the practice. 13 studies, 1,759 couples went into this Cochrane database. And what did they see? Different protocol for glucocorticoid, different type of glucocorticoid, different doses and schedule, lengths of time. Again, very difficult to mix the oranges and the apple. Also the timing of treatment, luteal phase, follicular phase, both, oocyte level, etc., etc. Nevertheless, this is what we have. So, no significant difference, overall results. Not in live birth rate, not in pregnancy rate, and not in miscarriage rate per couple. Again, these studies have been done in regular IVF cycles. So, they did find an improvement in IVF, but not ICSI pregnancy rates, with a borderline statistical significance. It's difficult to understand why it should help in IVF and not in ICSI. Let's think about it. These findings are really limited to the routine use and cannot be extrapolated to women with autoantibodies, unexplained infertility, or recurrent implantation failure. Evidence does support steroid use in women with non-organ specific antibodies, combination of assisted hatching, and in women with advanced maternal age or FSH more than 10, by a study done by Busma et al. So, in conclusion, will I give a corticosteroid to a woman that failed 9 or 10 times? I'll try to assess if she has any autoimmune disease, if she is a hyperandrogenism, etc. But there is no evidence. What about growth hormone? Growth hormone increases intra-ovarian production of IGF-1. And you know that IGF-1 increases gonadotropin action on the ovary. It augments the beta-estradiol, the progesterone, and the LH formation, receptor formation. And IGF also stimulates follicular development, estrogen, and the oocyte maturation. It has been shown to act on the ovaries independently from IGF-1, in 2 routes, one through action on the IGF-1 and even independently. So, I've gathered for you 10 studies with 440 couples, and there is no evidence the routine use of growth hormone affected the outcome of live birth. However, women who responded poorly to IVF had an increase in live births when treated with growth hormone. And this is good for us, because if I have a patient that she has repeated failures and she's also a poor responder, maybe growth hormone will be good for her. And now to the dehydroepiandrosterone. This is something novel, is now coming like hot from the oven, and is going to be very popular, I guess. Dehydroepiandrosterone is essential substrate for steroidogenesis. As you know, androgens act with FSH to stimulate follicular differentiation and recruitment. It also increases the IGF-1 in the ovary. So during ovulation induction with gonadotropin, DHEA is a pre-hormone for up to 48% of follicular fluid testosterone. Testosterone, as you know, is a pre-hormone for estradiol, which is good for us. This is the theory. And so there are some studies that checked the effect of DHEA on oocyte and embryo yield, embryo grade, and cell number in IVF. How do we treat with, the studies that use DHEA, fortunately they use all the same dose and the same length, which is good. It is 75 milligrams of DHEA daily, 25 milligrams 3 times a day, for an average of 3 to 4 months. And analysis of IVL cycle outcome in 25 patients, this is a pilot study, who underwent cycles both before and after DHEA supplements, showed significant increase in fertilized oocytes, normal day 3 embryos transferred, and the average embryo score per oocyte. And this was amazing when it was published first in 2006, although the population number of patients was very small.